Welcome to the Explainer, everyone. If you've ever looked at an echocardiography report, you've probably run smack into what feels like this intimidating wall of hemodynamic data. I mean, it's a lot, right? Well, today we're going to demystify those numbers. We're going to take all that confusing jargon and transform it into clear, actionable clinical knowledge. Let's get into it. You see terms thrown around like peak gradient, mean gradient, RVSP, and aortic valve gradients. And you might be wondering, what do these numbers actually mean? Where do they even come from? Honestly, it's really easy to just look at a report, accept the numbers at face value, and move on. But today, we're peeling back the layers. We are going to figure out exactly how these numbers are generated, and more importantly, how they help us make absolutely critical clinical decisions for our patients. So here's our roadmap for today. First, we'll cover what a pressure gradient actually is. Then, the physics of blood flow. Third, the cornerstone Bernoulli equation. Fourth, we'll compare peak versus mean gradients. Fifth, we'll dive into some real-world clinical applications. And finally, number 6, pitfalls and the golden rule. All right, starting off with section 1. What is a pressure gradient? The absolute basics.
Okay, let's just strip away the complex medical terms for a second. At its core, a pressure gradient is simply the difference in pressure between two locations. Think about our cardiovascular system. Blood naturally flows from areas of high pressure to areas of low pressure. It's just following the path of least resistance, right? But whenever blood hits a narrowed structure, say a really stiff stenotic valve or a pinched blood vessel, it actually has to accelerate just to keep moving forward. And as that velocity shoots up, a measurable difference in pressure pops up across that narrowed area. That difference? That is our pressure gradient. So the worse the obstruction, the faster the blood moves, and boom, the bigger your pressure gradient.
Moving on to section 2, the physics of blood flow, visualizing the system. To really visualize this, imagine you're holding a standard garden hose. When the water is just flowing normally out of the open end, the speed is pretty steady, right? Nothing crazy. But what happens when you jam your thumb over the opening? You're narrowing the exit, and suddenly the water shoots out way, way faster. Well, the exact same principle is happening inside the human heart. When blood gets forced through a stenotic valve, it's like putting your thumb over that hose. The flow velocity spikes, the kinetic energy shoots up, and massive pressure differences develop. This simple, everyday physical reaction is literally the entire foundation of Doppler echocardiography. Now, I cannot stress this next point enough. This is absolutely crucial. Doppler does not measure pressure. Doppler measures velocity. When you're holding that ultrasound probe, the machine is only recording how fast the blood is moving. It has literally no clue what the actual pressure inside the heart is. 0. We have to use math to convert that speed into a pressure gradient. So remember, velocity is the real measurement we take, and the pressure, that's entirely calculated. Which brings us right into section 3, the cornerstone Bernoulli equation. From speed to pressure. Enter the Modified Bernoulli Equation. It's beautifully simple. Delta P equals 4V squared. Delta P is your pressure gradient in millimeters of mercury, and V is your velocity in meters per second. This little formula is the magical key we use every single day in echo. It is exactly how we translate speed into actionable clinical data to evaluate valve disease, estimate pulmonary pressures, and figure out what's going on hemodynamically. Now, take a look at this. This brilliantly illustrates what we like to call the power of squares. Because velocity is squared in our equation, even a tiny little bump in velocity creates a massive exponential leap in the pressure gradient. Check out how this plays out in the numbers. A velocity of 1 meter per second gives you a tiny gradient of 4. But if you just double that velocity to 2 meters per second, the gradient quadruples to 16. Push it up to 4 meters per second, and bam, suddenly you're looking at a gradient of 64. This right here is exactly why your Doppler measurements have to be so incredibly precise. Just a microscopic error in measuring velocity is going to completely throw off your calculated pressure.
Okay, moving right along to section 4, peak versus mean gradients, cardiac cycle timing.
We really need to contrast these two concepts because they get mixed up a lot. Peak gradient is the maximum instantaneous pressure difference. We calculate it using the absolute highest single velocity point recorded during the cardiac cycle. Think of it as the worst moment of blood flow. On the flip side, we have the mean gradient. This evaluates the entire Doppler envelope. It gives us the average pressure difference over the entire flow period. And because the mean takes that whole waveform into account, it gives us a much more accurate picture of the true hemodynamic burden, the actual average workload the heart is dealing with, compared to just cherry-picking that one single peak moment. Let's look at section 5, real-world clinical applications, evaluating disease. So the real so what here is how we actually use these numbers in practice to guide patient care. These velocity and gradient thresholds are our diagnostic markers for severe valve stenosis. For example, with aortic stenosis, we're looking for a peak velocity of 4 meters per second or higher and a mean gradient of 40 or higher. For pulmonary stenosis, it's similar, a peak velocity over 4, which gives us a peak gradient over 64. Now, for mitral stenosis, because the flow happens during diastole, that mean gradient becomes super important. We're usually looking for a mean over 10. But hey, a quick reminder, always interpret these parameters alongside other findings, like valve area. Never use just one single measurement in isolation. Now, let's break down a very common one, calculating the right ventricular systolic pressure, or RVSP. We use this all the time to evaluate pulmonary hypertension, and it's basically a super simple 3-step recipe using tricuspid regurgitation, or TR. Step 1, you square your peak TR velocity. So let's say it's 3 meters per second. 3 squared is 9. Step 2, multiply that by 4. 4 times 9 is 36 millimeters of mercury. And step 3, just add your estimated right atrial pressure. If we estimate that at 10, then 36 plus 10 gives us an RVSP of 46. It's simple, it's elegant, and it tells us so much. And beyond basic valve stenosis, these gradients are just incredibly versatile. I mean, we use them for checking coarctation of the aorta, looking for dynamic outflow tract obstructions and hypertrophic obstructive cardiopathy. We use them to evaluate intracardiac shunts, manage complex congenital heart disease, and critically assess how well prosthetic valves are working. Honestly, they are literally the vital signs of echocardiography. Finally, Section 6, Pitfalls and the Golden Rule, Avoiding Errors. Look, even perfect math is going to fail if you feed it bad data. Things like suboptimal acoustic windows, incomplete envelopes, or just ignoring the whole clinical context, those are big pitfalls. But the absolute biggest enemy here is poor Doppler alignment. Your ultrasound beam has to be as parallel to the blood flow as humanly possible. Any angle error, seriously, any at all, will underestimate the velocity. And because of that squared formula we talked about, if you underestimate that velocity even a tiny bit, you're going to drastically, exponentially underestimate the clinical gradient. So let this be the golden rule you scan by. Doppler measures velocity, not pressure. Say it with me. The pressure gradients are just mathematical estimates derived from those speeds. Therefore, better physical alignment gives you better velocity measurements. Better velocity measurements give you accurate pressure gradients. And those accurate pressure gradients, they lead to better, life-saving clinical decisions. Ultimately, pressure gradients are way more than just confusing numbers on a page. They are literal cardiovascular physics translated directly into clinical medicine. So I want to leave you with this to ponder. If just a single millimeter of ultrasound beam misalignment squares into a massive diagnostic error, how will you ensure your velocity measurements are absolutely flawless to protect your patients? Because mastering the physical setup is the only way you'll ever master the clinical math. Measure carefully, interpret clinically, and treat wisely. Thanks so much for joining me for this explainer, and keep learning.